Good morning. Dr. Sean Mutashmi here with you to discuss the All-on-4 treatment option, its workflow, and how to incorporate it into your dental practices. My email is dr.seanmutashmi@gmail.com. Feel free to email me with any questions later on. I consider myself a lifelong learner. I've gone through all phases of dentistry in my 23 years of career. About 10 years ago, though, I fell in love with implant dentistry, and I've pretty much limited my practice to implants and All-on-4. And it has changed my life. Let's start by just briefly talking about what the All-on-4 treatment solution is. The All-on-4 is a graftless solution for full arch immediate function. There are three important words here. Graftless, meaning that there is no sinus lift, no ridge augmentation needed. It is obviously for full arch treatment. And number three is immediate function, meaning that patients leave your practice same day with fixed prosthesis. There are 4 implants involved per arch, 2 posterior and 2 anterior. And these 4 implants provide a secure and optimal support for a fixed solution. The 2 posterior implants are placed in an angle, or we call it tilted implants, up to 45 degrees. That's what helps this procedure to be so successful, even in minimal available bone, or at some cases, very little available bone. And we'll talk about that a little further. But what the tilted implant brings to us is the tilted implant increases the bone to implant contact because we're using longer implants, and that's one. It also helps to increase the AP spread, or anterior-posterior spread. By increasing the anterior-posterior spread, it helps us to reduce the length of our cantilever, and having a short cantilever long-term increases the success of these prosthetics. It also, the tilted implants helps us to avoid anatomical structure, such as an upper sinus or a lower mental foramen. We're also able to use the anterior, or we're also able to anchor the implant in a better quality anterior bone, but yet have the coronal part of the implant as posterior as possible. These are some of the advantages of using the tilted implants, and altogether, basically, this creates a optimal prosthetic support for all acrylic, provisional, or various options that are used for final restorations. So you can kind of see the benefits of tilted implants. But tilted implants were being used, long ago. They're nothing new. What really changed this whole All-on-4 to be so advantageous was the multi-unit angle abutments. These come in straight 17 and 30 degree abutments. But what it does for the 4 implants is allows them to all be in the same path of insertion, being parallel for your final prosthesis to be passive. That really is very important. Now, you can see in this photograph that the posterior implants are placed in an angle, but by using the 30-degree multi-unit abutments and the straight ones for the anteriors, now we have created a nice passive path of insertion. So those titanium cylinders, imagine being your prosthesis, that are going to very passively insert on top of the abutments, screw in, and again, this allows you to immediately load and give full function to patients on the same appointment. Now let's talk about surgical instrumentation a little bit here. So I've used many different implant systems in the last 10 to 12 years, but my most favorite by far is the Noble Active implant system. There are a lot of benefits to it, but just to name a few of them, because of its design, it has a really sharp and long threads. It gives you that primary stability, even in poor quality bone, which that happens a lot in the maxilla, as we all know. We're still able to get the torque that we need because we can under prep the osteotomy and with these implants and still be able to place the implant because of its thread design. It's also self-drilling, tactile placement, so I can very much feel the direction and how this implant is basically being inserted into the bone. It has an apical drilling blades that helps me in that section. Like I said, it allows me to get a really high torque up to even 70 Newton centimeter, which is very ideal for immediate loading in these cases. It's controllable direction of insertion. It has a counter clockwise cutting effect. That counterclockwise helps me to, even if my osteotomy is a bit off, I can still move my implant as it's being inserted. Sometimes I need to place it a little bit more palatally or tilted mesial distally, and this implant system allows me to do that. The most important feature for me is the abutment connection with tight conical seal. Conical is a really key word here. Any implant system you use for the All-on-4 solution, you have to make sure that it's a conical connection between the abutment and the implant. And what that means is the long connection that comes kind of like having two beer glasses that are inside each other. When you pick up the top beer glass, the second one goes with it. So in this case, if you once you have the conical connection, if for whatever reason your abutment screw becomes loose, your abutment still is in contact with in a conical connection, and it does not start moving, and that reduces your implant failure by far. So no matter what implant system you use, make sure that it is a conical connection when it comes to the abutment. Also, it's stable and predictable hard and soft tissue outcome, which is nice because I really don't see any bone recession around these implants. The actual implants that we can use with the multi-units come in 3 different sizes. We have the narrow, we have the regular. The regular comes in 2 different widths, 4.3 and 5.0. The narrow is only 3.5. Obviously, they come in different lengths, but the actual width is only those 3 that you can use with your multi-unit. Couple of features of the multi-unit that's really important to know is there's that wide abutment shoulder that you can see here, the wide abutment shoulder that helps in a vertical stop of your prosthesis. So you always get that nice vertical stop. And then the other benefit or nice thing about it is it comes in different tissue heights, which is right here. So the way I look at it is I look at this multi-unit abutment as my crown prep. When I prep a crown, where do I want my margin to be? My margin is this shoulder. Do I want it to be subgingival, at gingival level, or supragingival? I guess it depends on where the crown is, right? The more posterior you go, the less subgingival you want to be. But ideally, you want to be at gingival level or slightly supragingival for cleaning purposes, for hygiene purposes, right? That same thing goes here. So at the time of surgery, you need to decide how thick your tissue is and figure out if you're going to use a 2.5 millimeter height, 3.5 millimeter, or 4.5 millimeter height abutment. and that's this part right here where it says tissue height. That determines where your margin or your shoulder is going to end up at the tissue level or slightly above the tissue level. Some of the other surgical instruments here, obviously it comes with a surgical kit that's pretty complete. You have just about everything you need. The middle picture here is a mallow guide, which if you're initially starting or if you're new at this, for sure you want to use this. It's a must. This mallow guide helps you to determine two things. Number one is where to place your implant, and number two is at what angle to place your implant. So you create a osteotomy with a number 2 drill right in the midline of the arch after you've done your reduction and done your teeth removal and all that. And once it's in the center, each one of these lines that you see here determines each tooth. So you have your central, lateral, canine, first bite, and second bite. Now this is flexible, and you can basically form it to the shape it to the arch form as needed, and you can decide on your anterior implants to be between the central and lateral, and how far back you can go considering the sinus or mental foramen for the posterior. So that's number one. Number two, it helps you as the angle. What angle are you going to place it? So considering this line here, for example, that's a 90 degree. If your drill is going to be at 45 less or more, you can kind of evaluate that as well. So you want to be at 45 degrees or less when you place your posterior implants. Some of the other armamentariums are, I always have a side cutting rongeur to be able to, before I do my reduction, to remove some or harvest some of the patient's bone as a autograft in case if I need it later. It comes handy. Then I have a surgical bone reduction burr and obviously a straight handpiece. Some of the prosthetic components that's needed, obviously a multi-unit. You want to make sure you have a good selection of straight, 17, 30 degree that comes at different heights, obviously, 2.5, 3.5, or 4.5 millimeter, considering your tissue thickness. You want to have impression copings, and these are all at multi-unit level, not at implant level, just so you understand. Everything now that we do is going to be on the multi-unit level because this is the interface between your implant and your prosthesis. So open tray impression coping is what I always have. Rarely ever I use the closed tray. Some of the lab components is going to be your temporary cylinder, which is going to be used for your conversion on the same day prosthesis. And then you have your multi-unit analog here, used for laboratory pour-up. And then you have for your prosthetic kit. Now let's talk about diagnostic and treatment planning. There's a lot to consider. I'm just going to go over some of the key points here as we're doing a 45-minute crash course on All-on-4. Don't have time to go through everything, but one of the important things is establish the patient's treatment objectives. Is patient priority aesthetic, function, health? What's patient's expectation considering his or her priority? I compare this to doing a set of veneer, a cosmetic case. You want to discuss with the patient what they think of a beautiful smile. Does it show any gums? Does it, white teeth, dark teeth, straight, round teeth versus square teeth, long versus short? I mean, there's so many things to consider that if you don't discuss these with the patient, you may set up yourself for failure because you may think of something and then you later on find out that patient completely thought it was something else. So this goes the same for an all-on-4 objectives here. You want to find out if that patient is expecting second molars or are they not? Because if they're expecting a second molar and your AP spread is not very long and you end up with possibly only a first molar pontic or cantilever, then now you're going to have a problem because the patient expects a second molar, and if you give it to them, you're going to have a possible failure long term. So it's really important to talk about these things and find out what patients' expectations are. Visualize the end result. Once you know patient's expectation, make sure that the end result can be delivered. Basically, educate the patient about the benefits, risks, worst case scenario, and alternative treatment if it differs from what their expectation is. One of the worst things that could possibly happen that I discuss with my patients is the possibility of a transitional denture. Here's you've sold a case or you talk to a patient about fixed teeth, same day, teeth in a day, and you look at the x-ray or whatnot and you realize that this case could be a little complicated. Well, if you don't discuss it with the patient that, hey, there are these issues and there's a chance that you may go home with a transitional denture or traditional denture for some time, whether it's 3 months up to 6 months, you don't discuss that, then you're setting up yourself for some issues with the patient. So it's good to discuss these things. Another very important subject is your photography. I don't want to discuss, how beautiful your photography needs to be. I just want to talk about that it is very important to have intra and extraoral photographs for many reasons, but a few of them to be able to record and communicate with your lab technician. And one other very important part of photography is to be able to really see the high smile line. Now, these are the photos we take. It's very complete. Do you need all of this? Not really. The ones that are the most important ones, obviously, are profile, full face, smiling. But more than that is this photo right down here. This photo is what I call the exaggerated smile. I've had patients that give me a smile like this up here, and I think that's their smile. Later on, I found out that this was really their smile, and I just miscalculated my measurements, which I'm going to discuss with you in a minute. So I always ask the patient to give me an exaggerated, goofiest, cheesiest smile they can possibly give me. And sometimes it's good to have their eyes closed when they do that because that helps them to give you that exaggerated smile. If they're looking at you, it's just hard for patients to give you that. So I ask them, why don't you close your eyes? If I feel like they can't give me that exaggerated smile, I say, why don't you close your eyes? Now give me the cheesiest smile you can possibly give me. And usually they do that, and that's I've learned that this really helps me. I'm going to show you a case in a minute. So then after that is my X-ray or CT scan diagnosis. One of the things that I use commonly is what's created by Dr. Bedrosian. We'll call it the bone zone. He said that, okay, from canine to canine, available bone is zone 1, bicuspids are zone 2, and molars are zone 3. I look at a CT scan or a pano, whatever it is, and right off the bat, I use this zone 1, zone 2, zone 3 to determine where my posterior implants are going to be. So if we have zone 1, zone 2, zone 3 present, I know it's an easy case. I know it's going to be great. My posterior implants are going to be far back enough to where my AP spread is wonderful. If I see that I only have zone 1 and zone 2, no zone 3, I'm still good because my posterior implants are going to be in the second bicuspid. Worst case scenario, we'll have one more cantilever in the molars, and that should be good considering patient's expectation. Where we fall into a little bit of problem and we need to plan ahead is if you have zone 1, either minimal zone 2 or no zone 2. Those are the cases where you're going to end up with your AP spread very short, long-term issues. You may not be able to convert or load the prosthesis same day. So if I see that right off the bat, there's going to be some discussion either with patient or I'm going to treatment plan a little differently. perhaps consider doing sinus lift, placing 6 implants instead of 4, so it becomes an all-on-6. And whether we're going to convert the same day with a shorter, arch or not, those are things that I really need to discuss with patients. So this zone 1, zone 2, zone 3 is very quick. Looking at the CT or panel, I immediately can decide on where my end result is going to be. So this is great. Now, the other thing that is really important is your interarch space. I also need to consider that we need a minimum of 17 millimeters of interarch space from the edge of, or from the edge of the from the incisal edge of your front tooth all the way up to the neck of the implant. It needs to be at least 17 millimeter, up to 20. And that's considering the height of the abutment, the actual length of the tooth, and possibly some tissue. Again, I'm going to go back to general dentistry. This is very similar to a crown prep that's under reduced. You can give a crown prep, under reduced crown prep, to a lab technician. They may give you a crown back, but there's some issues with that. Number one, easy to crack because the thickness is not there. Number two, aesthetic issues, especially if it's in the anterior, because they don't have the room to layer the porcelain or to block out any stump shade, dark stump shade, or whatever it is. So by giving the lab the proper reduction, you are setting yourself for success. Same thing here. If you don't do enough reduction, minimum 17 millimeter, you're going to set yourself up for some failure. I've done cases years ago that I'm still dealing with because I didn't do enough reduction, not having the experience, and patient every 6 months comes back with a tooth crack, or we have aesthetic issues and whatnot. So I really, really want to make sure that you understand this 17 millimeter reduction. Very important. Comes in hand in hand with the next subject that I want to talk about, which is the transitional zone. So the inner arch reduction or space that's needed with your transitional zone, they work together. Transitional zone is where your prosthesis and your ridge meet. So imagine you've had your reduction in this case, in this picture or a smile. I've measured my 17 millimeter and ends up there. And if I just go ahead and go with my traditional 17 millimeter reduction and do this case, guess what? We're going to have some issues later, because where my prosthesis and the ridge are going to meet is going to be below the gums or below the smile line. And that's a problem. Number one, it could cause aesthetic issue. Patients going to come to you and say, hey, I can see this line. What is this? It doesn't look good. I mean, it will not look good. And if you try to resolve that by doing what we call a wraparound, now you're creating hygiene problems. So it's really important to consider both the inner arch space and the transitional zone when you're measuring how much reduction to do. In this particular case, we're going to consider the 17 and add at least another 3 to 5 millimeter so I can get my transitional zone above the smile line. And this is where that big, cheesy, exaggerated smile comes into play. If you don't do this and you don't see it ahead of time, you're going to end up like this. This is a case, again, I did a long time ago. And obviously, I didn't see that exaggerated smile. I thought I did, proper reduction. Later, after delivering, patient comes back and says, oops, what is this line that's showing up when I smile? And that's when I said, oh my goodness, I have screwed up. So what are my choices here right now? If this happens, I only have two choices. One is to either go back and start over, remove those implants, reduce the ridge more, replace implants, and so on. Number two would be to raise those flanges, which it could be what we call a wraparound. Now, the problem with that is we're going to create some hygiene issues. Food is going to get plaque, is going to get impacted in there. Patient is not going to be able to clean it because you have this long flange. And again, longevity on these prosthetics is going to be jeopardized. So I highly recommend looking at your inner arch space with your transitional zone as a whole together, because your ideal situation is the picture on the right of the screen, this one here. You want to have a convex pontic design, not a concave. And if your transitional zone is not proper, it's not above the smile line, you're going to end up with this concave versus this convex. And this is going to be a food trap and hygiene problems. I think you can all see that pretty well. So let's say you've now measured and you know you want 20 millimeters of reduction from the incisal edge. There are two ways that I do that. Number one is after I open my flap, if patient has existing teeth, use either a peri-probe or a bowling gauge to measure from incisal edge up 20 millimeters, as you can see I'm doing here. And then I'm going to use a number 2 sterilized pencil to draw a line across the ridge here, as you see. Now I have a landmark as to where I need to reduce to. And I know this looks aggressive, but it's the only way to do it to basically resolve the interarch space, so you have a strong prosthesis, and to also overcome the aesthetic issues, which is the transitional zone. So now that I've marked this, I can remove the teeth, do my bone reduction to that level, and I'm pretty confident that I've covered all those. The second way, let's say patient doesn't have teeth, or you basically start a surgery, remove the teeth, and you realize, oops, I forgot to do that measurement. Well, you can always do it on your pre-made immediate denture that's fabricated. Now this, we're doing 17 millimeter, and it's a different case, but I, again, use that peri-probe from the incisal edge. I go up 17 millimeter, make 3 different marks in different areas, give that denture back to my either assistant or lab technician. They create those notches, it comes back. I do my reduction to where I think is proper, and I place the immediate denture in the patient's mouth, making sure that I'm placing a lot of pressure on the palate where nothing has changed, and look through those windows and make sure I have enough reduction. If I don't, I'll remove the denture, do more reduction, and test it again. So this kind of confirms that I have enough reduction. And so the objectives for bone reduction, just to kind of review it, is to create vertical restorative space for the final prosthesis, and to make sure that the transitional zone is not visible. So now that you've done your reduction, you're going to place your malloguide, like we talked earlier, in the midline, create a midline incision or osteotomy, I mean, and place your malloguide, form it to the ridge, and always place your posterior implants first and then your anterior. The reason being is because your posterior implants are dictated by your sinus or mental foramen. So you need to place those first and then figure out where you're going to put your anteriors. Sometimes if your anterior wall of the sinus is kind of forward, and if you've already placed your anterior implants, you're going to find it difficult to position your posterior implants because the apex of those implants could be touching each other. So, but since you have plenty of room for the anterior, placing your posterior first and then your anterior will kind of resolve that issue. Here's the same thing for the lower. You're going to place your midline osteotomy, place your malloguide, and then place your posterior angle tilted implants, and then you place your anterior. You choose your multi-unit abutments, whether it's 30 degrees in the posterior or sometimes straight, or sometimes 17 degrees on the anterior, depending on the arch form. What you do want to make sure, though, is whatever angles you use, at the end of it, you have 4 parallel abutments. As you can see here with these abutment holders, these metals are basically what you hold the abutment with. It also helps you to determine and be able to look and say, yes, these are all parallel, this looks great. And then you can go ahead and torque your abutments to 15 Newton centimeter and not more, because those screws are very tiny and you don't want to torque them more than 15. Once you have that, you can use your pre-made immediate denture, put some a bite registration material, place it back in place, make sure it's in the right place, in the right bite, and you are able to locate those abutments as to where they are, and your lab technician can create the little holes inside the denture to make sure that they're in the right place, to make sure that they are not coming through the front teeth. Let's say if they are, you would change your angles and use 17 or 30 degree as needed to be able to make sure that your access holes are behind or lingual palatal to the anterior teeth. Once you have figured out your 4 holes on the existing denture, there's 2 ways that you can convert your denture into the fixed prosthesis. First one is a direct, which what we do is we pick all 4 cylinders, we lute all 4 cylinders directly in the mouth. So after you've created your holes, you put your temporary cylinders on top of the abutments, you place a rubber dam, and you basically pick up or lute all 4 cylinders in the mouth. And then there's a second way called indirect, which in the indirect version, you pick up the 2 anteriors in the mouth, and you also take a full impression of the implants, and on a model cast, you can basically pick up the posterior ones and go to finish. Each has its, positive and negatives. The direct method is quicker, but a little bit more challenging to do it in the mouth. The indirect is longer, it takes longer, but there's more of the work is done outside of the mouth. So initially, if you're starting, I would definitely recommend doing the indirect version, where it's done in the mouth. It's easier for you to handle that. So let's go into the final prosthetic. So you've delivered your final or your temporary hybrid. Patient goes home. You never remove it in the next 4 months. You do see patients occasionally for post-op, but you will never remove it unless you absolutely have to. 4 months or so later, patient comes back here and you remove the temporary hybrid prosthesis and everything looks great. You're ready for second phase. You take 4 impression copings, open tray, place them on there. I recommend taking some photographs, or x-rays, to make sure that the implants are healthy and those are all seated. You take a tray and create the 4 holes so these can poke through the holes. Now you're ready for your impression. You can use heavy body with light body or putty with light body and take your impression. Whether you want to do this or give it to your lab is going to place 4 abutment analogs, screw those into the impression copings. Then they're going to use a soft tissue index first and then pour it up with stone. So the final pour up is going to look like this here. And now the lab is going to fabricate what we call a jig verification. A jig verification is this right here that should come back to you from a lab. This is to verify that your impression was 100% accurate. What you do is you remove patient's temporary hybrid, you try this in place, and you use what we call a 1 screw technique. You place it in, make sure first of all it's passively sitting. You screw on one of those impression copings, making sure that the jig verification does not tilt or move. All 4, even though you've only tightened 1 screw, all 4 should be nicely passively seating. You do that with every single one of them. you unscrew one, and then you do the other one, and you go through all 4 of them. If all 4 are passively sitting, there's no tilt or movement, then that's a confirmation that your impression was 100% accurate. But if at some point one tilts and moves, when you screw the metal one, the other side moves, or anything that's out of the ordinary, you need to, as you can see in this picture, you cut through the jig verification, and you can relute it in the mouth. Whether it's one or, in this picture it shows 3 different sections was reluted. Most likely this one particular kind of was rocking all over the place. So what we did was we cut all 3 and we reluted the whole thing in the mouth. Now you can use either acrylic or Duralay and relute this. Once you relute it, you want to go back and check the 1 screw technique again. And if you see that it's working, then you're ready for another impression. If not, cut it again and relute it again. You need to do that until the 1 screw technique is 100% accurate. Then, at that point, you're going to take another impression. Okay? So now, this goes back to the lab, and from there on, it's pretty much the same way as you would do a full mouth denture or whatnot. You do a bite wax trying to determine the bite. You do a teeth trying to determine the aesthetics and the position of the teeth. Once that's confirmed, now you're ready to go into your final restoration, which what we are presenting here is a Noble Procera CAD-CAM titanium bar. You definitely need to have all that other steps done before you go to this level, because that titanium bar that's CAD-CAM designed needs a certain thickness, and we also need to know where those teeth are in order to give it the right support. So you don't want to do it the other way around. You don't want to create the titanium bar first and then figure out where your teeth are going to be, because sometimes that bar is just not in the right position then to give it the right support. So with the help of Noble Biocare, you can basically get this titanium bar. And what goes above that, there are multiple choices. You can do just basically acrylic teeth. You can do PMMA. We use Zerpeak in our practices. And there's a few other options. That's totally up to you as to what you want to do. But yeah, this is how you go into your final restoration. And you basically end up delivering your final restoration, and you have a patient that's happily ever after. Now, there are a lot of advantages for this All-on-4, but it's really a simple surgical prosthetic procedure that most dentists can perform, unlike some of the other procedures. It requires, basically, if you're already placing implants, it really requires a weekend course. It can prepare you to begin closing these cases and completing them in your practice. There's a little bit of a learning curve, but once you go through that, then it really becomes very efficient. This is a very efficient procedure that can be done. Because it's so efficient, there's a high, basically, profit for the practice. It also reduces the cost for patients that require these full arch restorations. At $20,000 to $25,000 per arch versus at $35,000 to $40,000 per arch. So now you're going to get more patients that are going to demand for this procedure for the All-on-4. Number one, because it's a permanent solution same day. Number two, because of the lower cost and the high satisfaction that it brings to patients. Again, it's highly profitable for the doctor because of its efficiency. And knowing that Noble Biocare is right there assisting you in the whole process, from the surgical part to restoring it, they're going to be right there with you, helping you out. And it makes it really easy and predictable with the Noble Procera design. So these are all great recommendations. Now, going back to my own personal experience, like I mentioned, I've gone through all phases of dentistry, from endo to ortho to full mouth reconstructions, and so on. And it wasn't until the All-on-4, until I introduced the All-on-4 into my practices, where I saw some huge double or triple in my numbers. Literally within a year, or maybe it was 2 years at max, my numbers were 120% up, over doubled my numbers. This is huge. And I think the main reason is because there's just so many cases out there that there's so many patients out there that require this treatment, and by not enough dentists offering it, there's just so much to do for those of us that do offer it. There's an article that was put out at the Journal of Prosthetic Dentistry that by the year 2020, if you look at this final number here, which is important, forget the rest, by the end of 2020, there will be over 37 million fully edentulous patients. Now, we're talking about fully edentulous, meaning that if you times that 37 million by 2, you're going to have over 75 million arches to be treated. 75 million arches. Now, think about this. This is only edentulous patients. How many patients do we have that are partially edentulous, that are just kind of living with this ill-fitting partials or unaesthetically looking teeth, that would love to have a permanent solution? Do they know about it, is the question. We're not even calculating patients that have severe gum disease or bombed out teeth that really there's not an easy solution for them. When you bring all those patients into this number, the potentials are huge. They are huge. So I want to encourage all of you to really start doing these cases, because forget the money part of it. Look at these photos that I'm going to present here. These are some of the cases, the gentleman on the left here, that there's no other procedure that could fix this, all the issues he's having, from missing teeth to collapsed bite to a pseudo class 3 profile or jaw positioning. All that is corrected all in one day. In one procedure, this patient goes from this look to that look, not considering the fact that he has full function, full set of teeth, and looks 20 years younger. I mean, what other procedure can offer all this? Or let's look at this young lady here who is in her late 20s. She was suffering from a heavily gummy smile, obviously, that she was made fun of all her life. She also suffered from, I think it was amelogenesis imperfecta, where she had a mixture of permanent and baby teeth. I cannot look at the results. This is her first set of hybrid. This is about a couple of weeks after her surgery is what she looked like. That's a big transformation. We're not changing teeth here. We're changing lives. So here's another case of James that was obviously, as a young child, he was heavily involved in possibly drugs and soda pop, a lot of soda pop drinking. All his teeth were decayed, but he's so young that he didn't want to go into dentures. He was willing to keep those teeth, hang around, instead of going into, a set of dentures. Once this procedure was offered to him, he jumped on it. I mean, he loved it. So what happened to my practice after a couple of years of introducing the All-on-4? I realized I'm working less, I'm making more money than ever, and I'm changing lives. I mean, those three things are a blessing. The three best things that could possibly happen to any dental practice. But is that enough to just learn the surgical procedure? And I'm sure there are a lot of courses that teach you the surgical procedure. Can you actually go back to your dental practice and start doing these cases? The answer is no. A lot of doctors think by just learning the surgical procedure, they're going to go back and do amazing, which with these cases, it's not true. You may be able to do 1 or 2 cases here and there, and then you start having some failure because you don't do enough of them, and you get discouraged. What's important is to have a complete infrastructure that can provide this service. What do I mean? That means, number one, you need to have some marketing, direct marketing to consumers to let them know that 60, 70 some million that we just talked about need to be aware that you're offering this procedure. Number one. Number two, let's say your marketing starts generating some phone calls. Are you set up for success? Are your people that are answering your phones, are they empathetic listeners? Are they able to convert those calls into appointments? Because these are not just regular phone calls that come in that says, hey, I want to get a cleaning. These patients have a lot of questions. These patients are afraid. There's just so many things that you need to be able to answer over the phone. So that infrastructure is very important. I also recommend for you to be recording and listening to your calls, not just yourself, but also your team members. People that answer calls learn so much from listening to these calls. It's a progression. Repetition of training is very important for the whole team, not just yourself. And I also recommend some incentive profit pay, meaning that have a goal that if we schedule 5 consults or if we sell 2 or 3 arches this month, I'm going to do such and such. Whether it's buying a lunch or giving him a $100 bonus or taking him out to dinner, whatever it is that you decide, you need to have those incentives in place to get the whole team involved and to get the whole team excited about it. So let's say you've done your marketing, you've got your patients calling in, and they turn into schedules. Now the second part is your treatment presentation. You obviously need to work on that. I have treatment coordinators that are specifically trained for this particular procedure. I put every treatment coordinator, every employee, but especially every treatment coordinator, every so often I put him through a surgery to watch surgery from start to finish. By doing so, they understand the concept. They see where the patient starts and where they end up. And through my consultations, I basically talk about what I can do for the patient, and the rest is really up to the treatment coordinator to be able to carry and walk that patient through the rest of it. Because it is a long journey, I won't have time to do it. My team members have to do it. And if your team members are not up to speed with you, if they're not trained properly, something's going to fall apart and these cases will not go through. So that's also a big part of it. Once you do all that put together, now what you have is happy patients, happy team, and really made a big change in dentistry overall. We all complain about there's so much competition out there, but trust me, there's not much competition in the All-on-4 treatment solution. I highly recommend it. We also have Forum Institute. Please visit us at foruminstitute.com for future All-on-4 courses where we actually teach and go through all the team training, phone calls, and marketing, and so much more. I want to thank you, and at this point we're going to go to Q&A, and I'll be available.
So I have some questions here that I will go through. I see them coming in. First question is, what's the placement protocol or sequence for tilted implants or axial implants? I think we covered that. I would definitely recommend placing the posterior implants first and then the anterior ones, just for the limitation of the sinus or the mental foramen. Second question says that you said you could tilt the implant up to 45 degrees. I assume posterior implants for this protocol, but the maximum angulation of the multi-unit abutment is 30 degrees. How do you compensate for the other 15 degrees, assuming your plan is to be near parallel. So yes, that's a very good question. So if I end up having to do let's say 45-degree angle abutment on the posterior, the way I compensate is I would use a 17-degree on the anterior. So that corrects that 15-degree or so they're both parallel. Sometimes, once in a blue moon, I may even have to use a 30-degree on the anterior, because even the anterior implant is placed not purposely, but because of the way the ridge is placed in an angle coming more facial. So now you have an implant that posteriorly is angled, and you have an anterior implant that's anteriorly angled. So in order to compensate for that, you're going to need 230 degrees to bring them together. So that should resolve that. The next question is, how about using Botox in this situation instead of more bone reduction? I guess that could be an option if you discuss it with patient and you're comfortable that you can change a patient's smile with Botox properly and permanently. I mean, I wouldn't want to take that risk for sure. I'd rather reduce 2, 3, 4 millimeters of ridge to be 100% confident that I'm never going to have that problem. It's unpredictable with Botox, I would think so. But I guess you could try it if the patient is willing to. When you're doing alveoplasty to develop interocclusal room, how do you safely remove bone with respect to the insides of canal? Again, good question. The insides of canal is very much on the palatal. And I always use, one of my assistants can basically use a periosteal elevator to protect it while I'm reducing. I've never had an issue, never had a numbness. It really is very much protected. It's so far back in the palatal with a simple periosteal elevator holding that tissue, holding the canal. You can still do your reduction without really damaging it. It's pretty safe. If there is not rocking inside the first try, do you still need a new impression? If you're 100% sure, absolutely, that you did your one screw technique and you did not get any rocking whatsoever, all 4 implants were solid, passive, sitting, then yes, you do not need a new impression, 100%. How much is total lab cost? This really depends, I guess, on the material you're going to be using. I would say average for final restoration should be around $3,000. Could be a little less if you're using just a bar and acrylic. It could be a little more if you're really using full zirconia, very cosmetic, layered zirconia. So I would say average around $3,000. What kind of demographics for an area do you think are needed to support this kind of practice? Honestly, I have 4 practices. I have practices in a high end. I have practices in blue collar area. I would say an average, a blue collar would be a good demographics. But you're going to find that it really is, you can have an office anywhere. These patients are all over the place. I mean, that 70 million that we talked about, plus all those other patients with partials, the baby boomers are huge right now. I would not worry about where my location is or what demographics. I would do a lot of vast direct marketing to consumers, and they'll just, most likely, you are one of the very few that's going to start providing this service in your area. So people will hear about you. I have people that drive from, they fly in actually from other locations, not just drive, but drive for hours to get to us to be able to do this procedure, because their dentist either don't know or does not offer this procedure. And when they hear my marketing, we get a lot of calls. So I wouldn't worry about that. Let's see. What kind of demographics? And when I'm back. Good. Okay. All right. Sorry about that. I guess I got disconnected real quick. So going back to free-handed, I'm assuming you're talking about guided surgery. We just don't have enough time to go over that. By guided surgery, definitely, I've done many. Depending on the cases, there's a lot of these patients come to me with a lot of infection, a lot of issues where guided makes it a little tough. So those cases I do not do guided. But if you're starting, I would 100% recommend learning how to do the surgery without a guide, and at some point you can move into a guide. If you don't know how to use the actual, if you don't know how to do the surgery, starting A through Z, if you're using a guide, there are times where you're going to come across issues with the guide. I don't care how nicely it's done. You need to know how to take over if a guide is not exactly working 100%. So I always give the example of, my daughter's, when she was learning how to drive or parallel park, she wanted to completely depend on the screen. And I told her, no, you need to learn how to parallel park first. Once you learn that, then you can use your screen, your cameras, and go from there. So I would say the same thing here. Guided is great. Learn how to do the procedure and then use the guide. Pain management protocol and expected outcomes after surgery. Just like anything else we do, there are different, each patient really is different. I have patients that absolutely don't even use any kind of pain medication. None. They come 2-3 days later. They're ecstatic how amazing this felt, no pain. But then I have those patients that swell up and bruise and they're in pain for a whole week. I always tell my patients that third day is usually the worst, just like any other surgery. Expect some swelling, expect some bruising. Those are normal. But overall, it's not as bad as you think. I usually do a 2-week post-op with patients because I've learned that if I do the post-op within the first week, those who are swollen and bruised are kind of a little bit complaining. And so when it's 2 weeks, they've already passed that stage. They're just happy about their smile. They're happy about their teeth. It makes those post-ops really, really much more pleasurable. Next question is, are the implants used for All-on-4 primarily tapered or parallel? Depends on the system that you're using, the implant system. But for Noble Biocare, I use the tapered, the active for the uppers, and I use the parallel for the lowers. Obviously, lower jaw, denser bone, higher quality bone. You want to use the parallel so you're not putting a lot of torque, a lot of force into the implant or the surrounding bone. So that's how I do it. I usually use parallel for the lower and tapered and the more aggressive for the upper. Are these under general sedation or local? Where can I get additional training to perform these procedures in my practice? So I am licensed to IV sedate my patients. So all my patients are IV sedated. I've done a few cases under local. Do I recommend it? No, because it is a long procedure, especially if you're initially doing this. You want to have that peace of mind that the patient sleep. You're not worried about the patient. If the procedure takes you 4 hours or 5 hours instead of 2 hours, you're not dealing with the patient that's uncomfortable, that's nagging. So I would 100% recommend, if you're not licensed yourself, to bring in a GA who can sedate these patients. It makes your life so much easier. It just takes away a lot of pressure so you can focus on the actual procedure. But my patients are all being sedated. Once in a blue moon, if a patient is really, really medically compromised, I do bring in a GA myself. but besides that, I recommend. Where can I get more training? There are multiple places that offer this training, but the one that's the most complete is at 4M Institute, 4minstitute.com. I think the next course coming up is in July. We had unfortunately to cancel the April course, but in that course you're going to get hands-on, you're going to get to see a live surgery, you're going to get to hear and go through all the training, the team training, and the marketing. So it's a really, really complete, and the restorative part, how to restore. How you decide 17mm interarch space in patient who lost vertical length of face or lack of vertical dimension. That's actually a really good question. So if this patient has, I'm assuming you're talking about a patient that is wearing dentures and has lost a lot of vertical dimension and so on, I would treat this patient as if I'm going to make him a new set of dentures. Okay, what are the steps you would go? You would obviously find the proper video on the patient. You would do a whole trying with teeth. So I would go through all those steps, make sure aesthetically, vertically, or you can even make him a denture and let him wear it for some time. So once I have that determined, I have my video, my length of the teeth, and the everything figured out, then, like I showed you on that video, I would go from that incisal edge, measure my 17mm, and use that denture as my guide in surgery. I hope that answered your question. You guys are always welcome to email me afterwards, and I'll be happy to answer more questions if I'm not being very clear. Do you see any failure with bone loss over years on the posterior implants? I mean, obviously failure is part of implant dentistry. Is the failure that I get from All-on-4 a lot more versus a single implant dentistry? Not really. I do have about, maybe I would say an average of about 5%, actually maybe a little more, 7% failure. But the reason that is because we treat a lot of smokers as well and a lot of diabetic patients. And I find those failures, whether it's posterior or anterior, they come from those patients that are either smokers or they have some kind of immune deficiency, such as diabetics, or absolutely patients that are careless and they never come back for their hygienes, and they have home care issues. Now, if your question is, do I get more bone loss because of the angled implants? No, I do not. I just don't see that. Angled implants are, if not better, just as good as placing them vertical. Okay, so what are the limitations of predictability offering 4 rather than more implants? Now, research has shown that if you get the primary stability, meaning that getting a torque on all those 4 implants of 35 or more, there's absolutely no need to place more implants. It makes no difference whether you have 4 secure implants or 5 secure implants. The only time I would recommend placing 5 or sometimes 6 is if I have 1 or 2 implants that are low torqued, less than 35 or possibly less than 30. Then I would add an additional implant just for that reason. You want obviously your full amount of torque and an arch to be over 120 Newton centimeter. So you want to do whatever it takes to get there, whether it's placing 5 implants or 6 implants. But I also have placed 5 implants because on upper right, for example, my upper right posterior implant was little torqued, less than 35, and I had some zone 3 bone available just for security, for I guess insurance. I placed a 5th implant. But again, going back to 4 versus 5. If the 4 are 100% stable and you get the torque you need, it makes no difference to place a 5th implant. Does having an anterior angulation, if it cannot be straight, affect AP spread at all? Does having an anterior angulation, not sure if I understand your question well, but if this goes back to that same question, if my anterior is also angled, by being able to use a 17 or 30 degree, I'm going to bring it back. Your goal is to have your anterior access holes behind or palatal to your front 4 teeth, however way it takes to get there. I hope that answered your question. If you want to do a case without pink gingiva, do you require as much ridge reduction? No, you can go down to 15. I've done cases down to 15, especially if you're using full zirconian prosthesis. I think you can go down to 15 millimeter and you're still okay. You said you would. You said you do not remove the temporary denture for 4 months after surgery. So does that mean you don't remove denture for suture removal? Correct. Correct. So we use obviously gut resorbable sutures. So if you go back to single implant dentistry, the most critical time of healing for implants is from 10 days to, I believe it's 8 weeks. During that time, you want to create no movement, no interruption to implant while the basically the bone is generating, integrating with the implant. So we use resorbable sutures, and we do not remove the denture for that period of time unless the denture is cracked or there's some kind of major issue. Then we have no choice but to remove it. So that answers that question, I hope. When completing the 1 screw test, are you evaluating just one implant only for passively, or are you evaluating each implant? We're evaluating each implant. That's why we do this 1 screw per implant. So I would screw 1 implant, making sure the whole jig is completely seated. Then I unscrew that one, then I screw the second one, and making sure the same thing happens. If I see I'm screwing the middle implant, for example, and the left one is raising, then I'm going to cut my jig section at that section when it's raising, and I'm going to test the other 3 and make sure that's the only one that's causing the issue. If it is, then that's the only one I would jig or relute. But to answer to your question is I will basically do that for every single implant. A lot of good questions here, but we can cover all of them. Do you have the experience of using facial scanner in all-on-4 digital implant placement design? Yes. So we actually have an in-house laboratory here, and this basically goes to kind of having a digital workflow. Is the digital workflow 100% there yet? We're working on it. We're probably 75% there. But yes, we do use the facial scanner. There's just too much to incorporate into all this to talk about. On the tilted implants, which one is the best position? Subcrystal, crystal, or subcrystal? Thank you. So this also, I think, depends on the implant system you're using, but you want to be, if you're tilting an implant, you want the mesial part of your implant be at the bone level. So therefore your abutment is not, or the bone is not interfering with your abutment. I think that's what you're asking. Excellent lecture, thank you. Do you ever use surgical guides with guide tubes when placing implants? Again, yes, we use we do guided surgery all the time. But again, in this lecture, there's just no time to talk about that. I would rather you learning how to do the actual surgery first and then going to guided surgery. Are you doing both arches same day under GA anesthesia? Yes, if a patient requires both arches, there's no reason to do one arch at a time. Patient is going to go through the same trouble, same discomfort, same medication, and not necessarily GA. I only use GA if there's medically compromised patient, but I do IV every patient, whether it's a single arch or double arch, it's an IV. On your first impression, can you floss? Can you use floss and acrylic on your first impression? Oh, an acrylic construction to connect them together for better accuracy. Yes, yes. We actually do that at times. What he's questioning is when you're taking your first final impression for the final prosthesis, do you connect the four impression copings and create a jig? So I've learned that I can do that in the mouth, but I still want to get that jig verification on a second appointment, if you understand. So no matter how you take that your first impression, whether you connect them or just take them normally, you still want to do that verification. So I don't want to spend that extra time in the patient's mouth trying to connect them if I'm going to do that second phase anyway. And it's a lot easier to connect, have a jig verification made outside of the mouth. And if it's not accurate, then we take that second impression with basically connecting the four as you're mentioning here, if that makes sense. So yes, you can do it. To me, it's a little extra work since I'm going to check and verify on the next appointment anyway. So, but you can do it. What is the indication of All-on-6? The indication of All-on-6 is AP spread if you want longer AP spread, if you have implants that are not initially torqued to 30 to 35. Those would be really the main two reasons why I would do All-on-6. What is the most effective outside marketing? I can't tell you if there's one effective marketing. You've got to basically do a variety of things. But initially when I started, obviously I did online marketing. Well, one of the other things that I did was I offered in-office seminars for our patients. In-office seminars, basically, you market to your existing patients, to the surrounding community, that on such and such date, we're going to have an hour free seminar talking about implant dentistry, talking about your options in implant dentistry, and you're welcome to come in for hors d'oeuvres and we'll answer all your questions. So I would put a marketing piece together. Patients would come in. We really would get 20, 25 people show up. We did that once a month for a long period of time. And that really started generating a lot of buzz in the community and getting cases going. So that would be, if I'm starting, I would go back to that. I don't do it anymore. I don't need to, but I would start with that. And then I think the second most is online marketing. Can you review the indirect conversion technique for the interim prosthesis? That's a little long for this. I only have 4 more minutes, but the indirect is you pick up the front 2 cylinders in the mouth by luting it. You remove it. You take a full-on open tray impression of the whole arch. You give it to your laboratory. They pour up the model. They screw on the front 2 denture into the model, and then they find the back two holes. and basically they lute and they finish outside. You would probably have to email me on a different note outside of here so I can go in more details. I'm sorry, there's just not enough time. How often do you find yourself needing to do major grafting for All-on-4? Major grafting, not often, but I always end up doing little grafting, and that's why I harvest patient's bone before I do my reduction. So major grafting such as sinus lift, I do 1 out of every 6-7 cases possibly, because I don't have enough AP spread. If my implants, you know, my zone 1 and zone 2, my zone 1 is there, my zone 2 is very limited or none, then I'm gonna need implants more posterior, so I end up doing grafting. Sometimes I'm able to even place the implant and bury it. Sometimes I'm not. Then I have to do a 2-step, meaning that go back and place implant. But that's very rare. 1 out of every 10 cases, I would say, maybe. What is your alternative implant if you find the anterior mandible bone is extremely dense? Parallel. Parallel implant is definitely it. Can you still do the immediate prosthesis if one of the fixture is not stable? You mean, I'm assuming you mean that one of the implants is not stable. I would, if I can place a 5th implant. Basically, I would still go ahead and do that. I have to wrap this up. What's the type of occlusion you select in immediate loading, opposing function, full function occlusion? I'm sorry, I have to go. They're telling me, I know there's about another 10, 15 questions here. I will have to answer some of these later. I appreciate you all joining. I'm hoping to, you're all welcome to email me on the side, and we'll be talking soon. Hopefully I'll see you at foruminstitute.com. Thanks.